Now I can see the meeting summary on the screen. Okay, and we will start with Cheryl Ramirez.
Here.
Chunwei Chi. Mary Lou Henrik.
Here.
Richard Gibson.
Here.
Jeff Goodman.
Here, and unfortunately, I will need to leave at 10 o'clock for about an hour.
Understood. Thank you. Chris Hogan. John Santa.
Here.
Bethany Stairs. And Charlie Swanson.
Here.
Thank you. So then Cheryl and Mimi, just keep an eye out for Chunwei, Chris Hogan, and Bethany Stairs. They're the three that haven't joined yet. And then from there, I will turn it back to Cheryl.
Thanks, Katie. I'm going to start with a couple of announcements. First, it's my pleasure to introduce our new executive director, Dr. Mimi McDonald, sorry. And I know it's Miriam, but you go by Mimi.
I do.
So I'm going to hand it over to you to provide a short background introduction on your own. So go ahead, Mimi.
Great, thank you. Well, thanks everyone so much. I'm just honored to be here. This is my first sort of official committee meeting as executive director. And I'm just, as I said, thrilled to be able to help facilitate this amazing work. It's been incredible to see how much has been done, and I really look forward to all the things that we have together in our future. So thank you so much.
Thanks, Mimi. The second announcement is to mention this procedure that the board voted on. It's a pause procedure, and we've been asked as committee chairs to provide some information on the pause procedure because we will be adopting this procedure as a committee too. We're not voting on it. It's just something that we're going to be doing. You will have seen it in your packet of materials electronically. So just to give you a very brief overview, we use the pause procedure when we have contentious discussions so that we can remain respectful, productive, and inclusive. And so again, this applies to both the board and all of the committees. It's just a point of order that either the committee chair can say or a committee member, so that we can stop unproductive, overly emotional and personal discussions, comments. And it just gives us a few minutes to pause and assess the next steps. And it will restate the ground rules about respectful interactions, and then we'll vote to continue. This also applies to public comments as well. So the committee chair can stop a public comment if it's not respectful, and we apply this procedure. So with that, I just want to ask if there are any questions. I know you may have read it, so it's like a 3-page policy. Or any comments? Okay. All right, moving along. Could you advance the slides? Whoever's doing that.
Cheryl, Cheryl,
Yes, go ahead, John.
this is John Santa. Could I just ask, is this a agency-wide PCBS, OHA sort of approach? I've done my share of public committees, commissions, etc., and I can't recall ever seeing this. So I'm just wondering, is this across the board now in the state of Oregon, or just here?
I don't think so, but I don't know the genesis of this policy. I wonder if either Mimi or Katie can speak to it.
Yes, I can. It is just, it was created by the vice chair and chair of the board, the Universal Health and Governance Board. So it's just related just for the board and its subsequent committees.
Mary Lou?
I just wanted to introduce myself since I.
Oh, I'm sorry. Yeah, we should have introduced you. Sorry about that. Go
That's
ahead.
okay. I just wanted to say hello. I'm Mary Lou Henrich, new member to the board, and I'm officially on this committee now. So anyway, I have a lot of years of experience in health and healthcare and public health, and I was the first executive director of Care Oregon for 10 years. So I've got some long time ago CCO experience too. So anyway, just wanted to say hello, and I'm here. Thank you.
Thank you for introducing yourself, and I'm sorry I missed that. I remember you introducing yourself at the board and it didn't occur to me. So I'm really glad you're on this committee and appreciate all of your expertise. So
Thanks.
happy
That's
to
all.
have you. So now we'll review the agenda for today. Could you advance to next slide? Oh, there's that. Okay. So we're going to just briefly summarize the feedback from our last meeting, which feels like a long time ago, but it was actually just about a month ago. We will go into a deeper dive of administrative costs because, as you recall, we felt like we hadn't spent enough time really talking about administrative costs and considering whether the estimate was accurate from the Optimist report, and which came through the task force, and then the RAND report. And hopefully you've read that material that we were sent. Then we'll go into the Echo Northwest scope of work. Our new consultants, I'm really excited to have them on board. They're going to review the scope of work and the first tasks that they will be working on. And I actually too, and I don't know if this is part of that discussion, I'd really like to figure out how we're going to get all the work done through September and whether we need to schedule additional meetings or not. So I'd like to really have a good handle on that. And then last, as usual, we'll have meeting reflections and talk about next meeting topics. And then we do have a public comment this time. Okay, next slide. Here we are. We're right in revenue options and the cost target. So that's where we'll be for a couple of months at least. Next slide. And as we mentioned, we need to pick back up on the administrative savings, and then we're in the middle of the revenue sources and parameters work. Next slide. Okay, here's the summary feedback, and if you notice that there's something missing, please raise your hand, speak up. We talked about further discussion needed around Medicare, whether it will be incorporated in the plan or it's separate. Need to consider the small business owner tax exemption. We talked about Social Security income not being taxable. We already had a request in for Echo Northwest to help us analyze and devise a way in which Oregon's corporate income tax will be neutral to employers. Also talked again about reserves and cited a need to dig into that further. And then this is a nice way of putting that we need a contingency plan with the changes in the federal administration and concerns about losing Medicare, Medicaid. We're probably going to need what I would call a worst case scenario plan. So yeah, that's what we've got as the summary. Charlie, did you have anything to add?
Yeah, so the fourth bullet with the Oregon corporate income tax will be neutral to employers. It's actually a combination of, well, it's whatever taxes are on employers that we discussed. Also an employer payroll tax. And so it's the combination of employer payroll tax and corporate income tax that should be revenue neutral.
Okay, thank you for adjusting that. Any other notes? Okay, let's move along. Okay. So now I'd like to welcome our guest, Don Osborne, who's Executive Director of the Vancouver Coastal Health in Vancouver, British Columbia. I don't have much more of an intro for Don, although I met with him along with others, and I was really fascinated with how to hear more about the Canada's system. It was pretty interesting, and we kind of teed up what we'll be focusing on today, which is the administrative costs. So I look forward to hearing from Don. Don, I'm hoping you'll do kind of an intro background like you did with us when you met with us, and then I would say we'll just open it up to questions and comments from the committee. I don't know if you may have slides. I'm not really sure. Do you have?
I didn't prepare slides.
That's fine.
no.
That's
I
fine.
figured it was question and answer.
Yeah, that's mainly what it
yeah,
is. Yeah,
yeah.
right. So please take it away, Don, and thank you so much for joining us today.
Thanks very much, Cheryl, and good morning, everyone. Nice to meet you. As Cheryl mentioned, my name's Don Osborne. I'm the Executive Director of Controllership for Vancouver Coastal Health, which essentially means I'm the controller on the accounting side of finance. I found out about the committee, or the committee found out about me through Charlie. So Charlie, just want to say hello and good morning. Nice to put a face to a name and a voice. So within British Columbia, most of health services are delivered by health authorities, and the health authorities are under the guidance of the Ministry of Health, which is part of the province of British Columbia's government. It's the largest ministry in terms of provincial budget by quite a significant margin over education. I didn't look up the overall provincial budget for healthcare before this meeting, but I can tell you the Vancouver Coastal Health budget is roughly around $6.2 billion annually. That's Canadian dollars. I was going to quip that that's about 2 million American dollars, but it's probably more like 4 and a bit billion. The things that in terms of sort of structure around the province, there are 7 health authorities. 5 of them are geographic, of which Vancouver Coastal Health is one. We actually cover the city of Vancouver and some of the suburbs, Richmond and North Vancouver, if you're familiar with Vancouver, Greater Vancouver, and also some of the areas up the coast a little bit, called the Sunshine Coast, Powell River. We don't oversee the island, the interior, the north, or even the Fraser Valley, which is a main part of sort of the Vancouver suburbs. So those are under different geographical health authorities. We do work together in some ways, and patients can go across. I actually live in Fraser Health, but sometimes when I get services, I go into Vancouver Coastal Health, just because. And in terms of the services, I mentioned the 5 geographical health authorities. There is also one that is a provincial health services authority. They handle some provincial services, ranging from the Children's and Women's Hospital, which is very specialized and serves patients from all across the province. The main cancer outpatient center for British Columbia, the BC Cancer Agency. They also have some provincial mental health institutions, including a forensic psychiatric institution. And they do some central administrative services for the province as well, which I'll get into in a little bit. And in addition to them, there's a First Nations Health Authority that handles a lot of contracts for health services to First Nations groups. So that's kind of the 7 health authorities. Within Vancouver Coastal Health, the services we provide, we operate acute care facilities. There aren't really public and private acute care facilities here in Canada are public. We're under the Canada Health Act. We have to provide services to patients whether or not they're able to pay. A small number of those facilities are operated by a Catholic healthcare group that we are affiliated with. They're called Providence Healthcare. They operate one of the biggest hospitals in Greater Vancouver called St. Paul's. Their funding flows from the Ministry of Health through Vancouver Coastal Health to Providence. And so that's sort of part of the flow through of funds from the province to them, but they are not a health authority themselves. They're sort of separate because of the Catholic affiliation or denomination. In addition to acute care services, we provide long-term care. So facility-based, we own and operate some of the facilities in our region. We also provide contracts for others that are public facilities, but aren't owned by Vancouver Coastal Health, so they can have either a nonprofit operator or a private for-profit operator. There are other long-term care facilities that are fully private within Vancouver Coastal Health region and other regions that actually don't get funding through Vancouver Coastal Health, so we don't necessarily have contracts with them. Although during COVID, when there was additional challenges in providing care, we did channel some support from the government through to those fully private ones, but there are some that are not funded through Vancouver Coastal Health. So there's sort of three: the owned and operated, the ones that we contract, and then fully private. We're also involved with home and community care services. That can be home nursing, home support. Home support is again both some of our own staff and some contract providers. We are also involved in mental health and substance use work. So that can include everything from inpatient psychiatry to mental health housing and group homes and other counseling services. Also some contracted services through there, so that you can tell that a lot of our service, well, we deliver a lot of services ourselves. There's also a lot of contract components. We're also involved with, because it's sort of a public system, really Vancouver Coastal Health is kind of involved in all of the services, other than some, private dental and those types of things that are operated by dentists and stuff. Most health services within the region are sort of either operated through or coordinated with Vancouver Coastal Health. So those public health services can range anything from sort of communicable disease control and epidemiology, environmental health testing, so water, those types of things, and even community care facilities licensing. And then there's corporate services, which I'll talk about a little bit more. In terms of I understand that you want to focus on I understand you want to focus on admin support. If there's anything I'm saying that's not making sense, or I know there's going to be questions at the end, but if you want to clarify something in the moment, feel free to interrupt me so I'm not just a talking head. And I'm happy to answer as best as I can. So our administrative and support functions or corporate functions, we have a target set by the provincial government. Not all of the health authorities are quite on the target, but the target is a 10% target. So of our $6 billion Canadian budget, we try to stay within 10% of that for what's considered admin and support costs. So hey, Charlie.
Yeah, so does that include the administrative costs within provider offices, within hospitals, within clinics?
It includes, it's more sort of a function based. So let's say within a hospital, we have an inpatient unit of whatever type, surgical, medical, the medical, if there's nursing unit clerks, if there's medical office assistants in that unit, they will not be considered in that 10% target. And when we flow funds out to most contracts, we aren't counting their admin and support in our 10% number. It's, if we're flowing money out to a long-term care facility, for us, that's counting as long-term care grouping. But we do say to our contracted service providers, and we're actually going through this now, that we expect them to try and stay within a 10% administrative target as well. We haven't really tried to enforce that in the past, but I was telling Cheryl, Mimi, and others when we had an earlier call that the provincial government right now is actually, just because of budget pressures, they're looking at trying to tighten admin support a little further here and reduce the areas that are over 10% and find savings where possible. So instead of, they may have to make reductions on the front line, but first it would be to look at admin and support costs and try to tighten those up as much as possible. And I can tell you what's included in our admin and support. So it includes our general administration, so our senior leadership team. It includes finance, human resources. It includes systems support, which is actually the biggest portion of our expenditures by quite a significant piece of our admin and support expenditures. And, you know, we've recently implemented a new clinical care system. It's called Cerner. Many American facilities use it. We've implemented that in acute care and for electronic medical record. Hi, Cheryl, go ahead.
Hi, just a quick question.
Yeah.
Could you repeat what that system is? And I'm not familiar with it. I'm sure others in the medical field are, but
It's Cerner. It's Cerner. C-E-R-N-E-R.
Okay.
Yeah.
Thank you.
I think it might be out of the Midwest somewhere, but so we've implemented that. Even though that's a clinical system, that is considered a corporate sector expense or an admin and support expense for us. And it was a very expensive system. But that counts in our 10% administrative target. So the electronic medical record clinical system is within there, as are, you know, other clinical systems and also our business systems. So that's all within that system support grouping. Yeah, Cheryl?
I have another question about that, mainly for the committee, because I was surprised to hear that this electronic health record, I think that's what that is, set system, is included in your admin costs. And I was curious to know if anyone here on the committee knows whether that is considered an administrative cost in the United States. And I don't remember I don't remember talking about including it as an administrative cost when we were coming up with the administrative cost estimate. Does anyone know? John?
Well, it's a huge part of a delivery system's administrative costs. Epic and Cerner are the two largest EMR companies in the United States. I know from when I was in Open Notes that a high priority of delivery systems at that time was to implement a more effective business system. And that was part of, I think, both Epic and Cerner's package. That's the billing system.
Right.
And so, you know, I don't think there's many payers, Kaiser being the exception, that likely contribute directly, like is going on here. It's very interesting, but you know, there's healthcare organizations that are paying hundreds of millions, if not more, for the information system, of which one part is the medical record, but some of the bigger parts may be related to business. Now, I know Richard has a sense of this and maybe should comment, but this is a huge administrative expense issue for us on, I think, normally the delivery system side.
Thanks, John. Mimi?
Yeah, thank you. I would just add in, just from my experience on the payer side, I completely agree with John Santa that usually that cost, you tend to think of it on the provider side. However, for example, in terms of, let's just say Epic, there is something called an Epic payer platform, which then the payer side would provide. And again, probably not nearly quite as expensive as it is on the provider side, but that payers can have to make that sort of seamless transition and eventually get to efficiency between the two entities. So there's a portion of that that can fall on the payer side. But I think it's an excellent point. Thank you.
Mary Lou?
Unmute. When this is a long time ago, but when I was at, we were forming Care Oregon, there were the various entities that were providing Oregon Health Plan. One of them was Kaiser, and Kaiser did not have any kind of billing system in place. They had no electronic whatever, and this was before EMRs were famous and out there, but it was just the simple coding system for services. Kaiser providers didn't have to do that. And it was a cost for places like Care Oregon, where we had, our providers out and about, and they needed to report to us. So it actually became a huge, big discussion and argument about the fact that Kaiser didn't have to have one of those, so they didn't have that cost. And when they were getting their per capita amount for people, they were getting the same amount that the others were getting that had to have this big expense. So anyway, ultimately, Kaiser did have to develop us and went to the Epic system. They were one of the first organizations that did Epic. But anyway, just an interesting, hadn't thought about it in a long time. So
Thanks, Mary Lou. And Don, as you can see, this is an important subtopic of administrative costs, and it
Yes, for sure.
yeah, gave me some red flags and wondering how we addressed it in our task force, and I did not remember. So back to you, Don.
Sure. And you know what, Cheryl, I'll continue to talk a little bit more about what's included in admin support, and then I'll come back and just speak a little bit to what we do for billing, because I think that's another area where we're going to be quite different from what you're seeing in Oregon. And and I'll get back to a little bit of the system stuff behind the billing as well, just quickly. So system support, yes, the biggest of the admin support costs for us. We also include communication in there as admin support, emergency preparedness. Not all of the emergency preparedness. We include the planning portion of it, but we don't include, I think, the actual implementation or steps to sort of prepare. So there's sort of a split. Material management and logistics, volunteer services, plant administration. So again, similar to my comment about system support, part of plant administration, plant operation, and plant security, that can be for any of our sites. So those, it may be for an owned and operated long-term care site. It may be for a large acute care site like Vancouver General Hospital. But even though that is a plant cost, we count that in more in support than admin, but we count it in admin and support within the 10%. And you might say, well, really operating the cost of an acute care hospital plant, wouldn't that be acute care? But for us, that comes in as a support cost. So I mentioned the plant administration, operation, and security, staff, some staff transport, which is small, translation services, small, registration. So that's a fairly important one, health records, and strategic health and development. So those are the things that are within those categories. There are a small number of exclusions that we factor out within our public health. Within our administration, we factor out our medical health officer. They're sort of responsible for communicable disease control, epidemiological monitoring, that type of stuff. We factor out infection control. we factor out from HR occupational health and safety. We factor out the out of logistics and material management, the sterilization and reprocessing. So medical device reprocessing and sterilization. So those things are sort of taken out of the admin categories that I mentioned. So having said that, I'll go back a little bit to systems. John?
Yeah, I didn't hear you use a term that became quite the issue at our former task force, and that's fraud and abuse. In your admin, where is fraud and abuse, and how extensive is it? How big a problem is it in Canada?
So it rolls up under our finance portfolio. We have an internal audit group, but I want to clarify sort of the specific fraud and abuse that you're referring to. Is that related to like cybercrime fraud and phishing and that type, or is it people coming in to sort of claim healthcare coverage status that they don't actually have?
Well, I think it might include all of those, but its major emphasis is, I think, on keeping track of providers to make sure that they're actually delivering the services that they're billing for, that they're billing for them correctly.
Okay.
And issues of that sort.
Okay. So a lot of the service provision is by Vancouver Coastal Health. But I did mention that we also have a lot of contracted service providers. So our internal audit team can be notified of organizations that we are funding that may be not providing services or using in the way that they're expected to and what's in their contract, or making, the most efficient use of funds. So our internal audit group it's written into our contracts that we can go out and audit providers through just the terms of the contract to make sure that they're using the funds appropriately. So yeah, that falls within the finance group. We also have a legal group that's within the administration team of the admin and support. And they can also get involved in those types of things. But then there's other, there's been all sorts of attempts from theft, which can be internal. We've had a mailroom break-in with people trying to steal corporate P cards and use those. Yeah, so you always got to stay vigilant on fraud.
Yeah, can you estimate what percent of your admin expenses are related to fraud and abuse activities?
I can do that. I would have to look it up, but it would be quite a small amount.
Yeah.
Like a percent of 1%, a fraction of 1%. It's not a huge spend. The Ministry of Health, and Charlie, I see your hand. I'll just be a sec. The Ministry of Health also does some auditing in a little bit of a different way, and I'll get into this in a bit, but for people who are beneficiaries in British Columbia of sort of the healthcare system, the services, there's no billing involved. So, when my father needed to go into the hospital, he went in there and all the services were covered. Now, there are some exceptions to that. If you're in a long-term care home, Some of that is considered sort of an accommodation. So there's ones that we provide, they're subsidized, but people have a co-payment. But the Ministry of Health does some auditing because sometimes people may not have coverage. They may be not fully living in Canada or not considered a resident, but they come in and get services here. And so there is a little bit of sort of after the fact checking to say, oh, really, that person had coverage and was a beneficiary or wasn't. So that's another thing. So Charlie, I'll turn it over to you.
So I've got a question about, I would assume that some of the services are just paid by budget. You hospital that you own and you just provide a budget for it. And I think that that's the same thing is true for the Catholic hospital, that you just provide them a budget overall. Are there some services that are paid fee for service that that providers submit what services they provided, or is it mostly are there some that are just contracted with salaries? So what's kind of the mix there?
That's a good question. And that really gets towards our sort of physician compensation. And that's sort of another, I haven't talked much about the billing piece, but within the billing group, there is a component that is for our fee for service physicians. So our physicians can have multiple arrangements. We don't have here for Vancouver Coastal Health, we don't have a lot of salary physicians. Our main physicians who are salaried are our medical health officers and our pathologists. We have a number of physicians on two types of contracts. One is a clinical services contract. It's really about what it says. It's clinical services. So it may be for orthopedics or cardiac or whatever, and they will be paid based on a contract. It's usually a team of physicians who specialize in that area, and they will determine sort of the allocation out of the contract amount that they get paid. We also have clinical and academic service contracts. It's the same sort of thing, but there's also a teaching component to the work they do, and they probably also have some affiliation with one of the university medical schools. So the main one here being the University of British Columbia, but they will also have some academic component to their contract for teaching. And then we have fee-for-service physicians. A lot of our radiologists and a number of our other contract physicians are on a fee-for-service basis. And that billing, there's a whole sort of schedule of billing codes that gets sort of automatically sent over through our revenue services group, our billing group, sent over to medical services plan, and there's payments back on a fee-for-service basis. Did I answer your question?
Yes, thanks.
Okay. And then I saw Mary's hand was up and went down. You're on mute. Sorry, Mary.
I was just being snarky, saying that you guys are Canadian. We need to remember that.
That's okay.
It was a
Yeah.
nice compliment in the situation that we find ourselves right now. I wish there was a way I could be Canadian. But anyway, thank you very much.
All right, thank you. So let me talk a little bit more about the billing function though. So we have, as one of the things that the government here did maybe 10 years back, and I'll say it's with mixed success. They tried to make administrative savings in two ways. They tried to consolidate certain services under, especially in what's called the lower mainland of Vancouver, under one health authority, and try to reduce the administrative costs and coordinate the services instead of having separate health authorities run those. Some of the areas they tried to do that in included pharmacy, medical imaging, labs, facilities, human resources, which didn't work, communications, which didn't work, information systems and technology, biomedical engineering, that's the majority of them. So they tried to combine those organizations together in the Lower Mainland and achieve efficiencies through that by enforcing a savings target on their budgets. Didn't work spectacularly. There are still some functions that are sort of centrally administered for the Lower Mainland, lab, medical imaging, but I'm not really sure that the savings targets were achieved. But that's one thing they did. The second thing they did is they tried to move to shared services for transaction-based processing. So the largest one being supply chain and logistics, but other ones that they tried to implement, accounts payable, which was those two have sort of proceeded. They also did payroll and billing and collection, which Vancouver Coastal Health signed on to, but most of the other health authorities in the province did not sign on to. So for our billing, it's actually performed by Provincial Health Services Authority. They perform that for their own operations, but they don't have a huge billing component. Vancouver Coastal Health, and they perform that for Providence, which is sort of funded through us. Our spend on billing is roughly $5.3 million a year. So on a budget of $6 billion, you know, most of our funding comes from the provincial government. Maybe little over five and a half, maybe closer to 5.3 billion comes from the provincial government. We do have some patient billing. It probably comes up to maybe 60 to $100 million. And we spend about 5 million a year on the billing function. As I mentioned before, most residents are covered. And so we would call them beneficiaries. Non-beneficiaries would be non-residents. They can be people traveling, visiting family from anywhere in the world. And we also have a category called uninsured residents. And for both uninsured residents and non-residents, if they require emergent care or urgent care, we are required to provide it whether they can pay or not. But when we do provide it, we are supposed to try to bill them. And one of the challenges, and I was saying this to Cheryl and Mimi and others when we had a conversation, is that we do have one of the groups that sort of falls into the uninsured residents category is our homeless NFA or population that struggles with mental health and substance abuse. So they're entitled to coverage. They're entitled to be beneficiaries, but they haven't been able to organize themselves well enough and get themselves registered. So when they present for care, and they often present, you know, if you're drug addicted or you're living on the street, homeless, whatever, your care issues are probably higher than most of the population. When they come in, we do provide them service, but we for acute care, but we are supposed to try and track them down and bill them, which for me is really quite a frustrating thing. I think, you know, we should be able to find a way to register patients who really should be residents, so that, you know, just because they haven't signed up, we aren't trying to chase them down and bill them. And even if we are able to locate them and present them with a bill, usually they're not going to have the resources to pay it anyway. So that is sort of one of the challenges. The other challenge is because we don't require a payment for patients coming in order to treat them, we sometimes feel we do get a bit of medical tourism from non-residents. We do try to collect, but our collections, if the person comes from overseas and does not have insurance, our collections can be quite challenging. So we probably collect about 65% of our non-resident billings. Charlie?
So what about residents, British Columbia residents from another region? Are they billed, or is that part of the system? And also, what about from other provinces?
Okay, a very good question. So if they're from another part of British Columbia, there's no billing. Right? If they're beneficiaries, that's fine. There's a lot of tertiary and quaternary services that are offered in Vancouver. If you have an accident and damage your spine, you're probably in BC, you're probably coming into Vancouver to get treatment for that. If you have leukemia and need a bone marrow transplant, you're likely coming into Vancouver to get services for that. If you're from another province, there's a billing that's called out of province. But if someone is registered from Alberta or Quebec and they and they're beneficiaries in their own province, if they can show that identification, they are not billed. Our province will bill Quebec, so we'll keep a record of it, or Alberta or whatever province they're from. And likewise, when British Columbians are traveling in Ontario or wherever and need care, there'd be a billing back to BC from Ontario or wherever they are. Does that answer that one? Okay, Cheryl?
I have a little cluster of questions that have come up for me.
Yeah, go for
First,
it.
I just want to make sure I have the numbers right. You said about 5.3 million is the cost of the billing administration out of was it a $60 billion budget?
No, a six billion.
Oh, I was
6
like,
billion.
wow.
Yeah, no, it's so a $6 billion budget.
Six
But remember,
billion.
yeah, $6 billion budget, 5.3 million spend on billing. But again, a lot of our funding, you know, the majority, well over 90%, comes through the province. And the province, there's a little bit that's kind of channeled through provincial health services. So the Ministry of Health gives it to provincial health services for what's called some provincial programs, and we get paid a little bit more on a sort of volume basis for those. So those are things like cardiac, renal, solid organ transplants. So those types of things. It's also provincial money, but it's flowing through a slightly different channel.
And
Yeah.
did you say that you do about $60 million of billing patients? Did I hear that correctly?
That's correct.
Okay, all right. There was a 60.
It was about 60 million for non-residents and uninsured residents. That's not including sort of billing to other provinces. It's not including the co-payments that people pay a portion of their long-term care monthly cost.
Okay.
Right, which is based on income. Their payment would be based on income. So yeah.
Well, that's something we might want to dig in further too with long-term care, because we've had a hard time grappling with long-term care. Might be outside the scope of this particular discussion, but
Sure.
So my other two questions were on different provider types. I'm sure committee members will know where I'm going here. So first, I thought I heard you say that dental care is separate. It's private, maybe more privatized. So how do you handle dental care? Do you like have subcontracts with dentists, or how does that work?
We don't do, so dental isn't really under Vancouver Coastal Health's jurisdiction. A little bit of a little bit. So if someone has like for me, I'm an employee of Vancouver Coastal Health. One of my benefits from my employer is dental coverage with so I can go to my dentist And it's Pacific Blue Cross is a sort of insurer for that. And so I can go and get dental services as a result. And as long as I'm sort of, if I'm not going in for cleaning every month, which I'm not doing, I have a hard enough time getting me in there every 4 months, probably, you know, and then as long as those types of things are in place, it's covered. If I'm getting things that are sort of outside the standard, like gum grafts or whatever, that might be a self-pay thing for me, but generally Vancouver Coastal Health isn't doing dental. Now, if someone has a major facial injury, that reconstructive piece, you're not going to be getting at your, you know, they're in a car accident and there's severe facial trauma.
Yeah.
You're not probably going to get that reconstruction happening in your dentist's office. That will probably be in an OR. And we do have people who do that sort of dental and sort of facial reconstruction or surgeries. But we wouldn't call that your sort of standard dental cleaning and hygiene. Right. That's
okay. Well,
yeah.
Interesting. So my other question is about behavioral health providers. You mentioned that you have fee-for-service agreements with physicians and there are other types of payment models. How do you pay behavioral health providers?
When you say behavioral health, what's
so mental
health
providers and also substance use disorder treatment providers.
I believe, oh, sorry, just a sec. I believe that most of them are through contract, maybe called a sessional contract. Like if they're, I'm not the best at physician compensation. I have a co-executive director who handles that. But I think we have contract, like agreements where we pay individuals for a session of medical time, and that may include some of the psychiatry. I think it's a 3.5 hour block is considered a session, and yeah, I'd have to dig into that a little bit more.
Okay, thanks.
Yeah. Oh, I'll make a note. Did you said you had a cluster of questions? Was that the cluster?
That was my cluster of questions.
Okay.
Thanks, Don.
John?
Yeah, just want to, I want to confirm that earlier you said the expectation was that on the delivery system side, that their administrative costs would also be in the 10% range.
Yes.
Do you have any sense of how much time, you know, a provider, a primary care provider, a surgeon, you know, you name it.
Yeah.
How much time are they spending on admin issues, i.e. Coding, pre-authorization, things of that sort. How much time are the providers themselves? You know, in the US, there are estimates suggesting that providers are now on average, and there's a big spectrum, with surgeons spending relatively little, primary care doctors spending a lot.
Yeah.
On admin, in any sense of that issue there?
Yes, there's certainly I'm not sure what their percentage would be. I'll be honest about that up front. I mean, I could maybe ask the physician and relations and compensation team if they have a sense of that, but yeah, I'm sure there's quite a bit of paperwork that goes with, you know, documenting all the patients they've seen and sort of getting that in. I know that they do, some of them use sort of private billing services for the fee-for-service work that they do, so that they're not spending the time themselves. But yeah, I'd have to look into that.
Thank you.
No worries.
A lot has changed.
But also Charlie?
Yeah, so what are there things like pre-authorizations? And also, are there metrics that need to be reported? Especially I'm thinking about like fee-for-service providers, and another related to that, what fraction of the expenditures are paid on a fee-for-service basis compared to, say, a budget basis?
Okay. That'd take me a little bit of looking up to do, like our fee for service. Yeah. Percentage. Can you repeat the first part of your question and I'll note it down? Like
Yeah, the first part was, what about pre-authorizations and
Okay, right.
and quality metrics, I guess.
I mean, I expect that the pre-authorizations, because it's for beneficiaries, I don't think we would have the same sort of pre-authorization requirement that a physician billing to a private insurer would have. So if the physician is seeing a beneficiary patient, British Columbia resident who signed up for healthcare services, and that person, in the physician's opinion, that person needs a knee replacement or a hip replacement. I don't believe there would necessarily be a pre-authorization required. Now, there is a sort of a medical quality and safety group that sort of reviews the work done by the physicians. And there's also a provincial physicians licensing body that may look at the work that physicians do. But yeah, I don't think the pre-authorization would be quite the same. Yeah, and I'm gonna look up just to get a sense of the size of our physician compensation piece and how much is fee for service. So, but you can keep asking me questions while I look that stuff up.
That's back. Like your nerves.
John?
Yeah, I think following on Charlie's example, how do you approach really expensive drugs? Here in the States, pre-authorization is almost universal for really expensive drugs that cost $10,000 a month.
Right.
More. That's a major source of pre-authorization. Is that an issue?
That is definitely an issue here. I believe the provincial government, they have a pharmacare program, and I believe they are the ones who make decisions around drug coverage, what's in and what's out. So it's not like doctors can just prescribe the latest, greatest, most expensive drug out there. I believe it has to get sort of that pharmacare approval prior to being put on the list. And I know it doesn't happen, well, probably happens with us. There is some funding that comes for very specialized drugs as well. I know like the Providence Healthcare deals with the HIV antivirals that also sort of comes through pharmacare. That is something that's covered for HIV positive patients, but they keep track of that, and that's a fairly high drug expenditure. That one actually comes through the Catholic. The Catholic group has the specialization or the provincial center of excellence for HIV treatment. And so the St. Paul's Hospital does a lot of that. So yeah, it's not a free-for-all when it comes to drugs. Yeah, we're probably, I'd imagine we might be delayed in terms of our introduction of new drugs compared to the American system.
But it sounds like the pharmacare folks do the authorization, not you.
No, it doesn't come to me. I wouldn't. The pharmacare probably has a team of pharmacists who are reviewing the latest sort of drug advances. So,
Yeah.
I mean, yeah, our research group works with drug companies doing clinical trials. But yeah, the introduction of new drugs, I believe, is through the Central Pharmacare Group.
Yeah, the point I'm trying to make is there's a single group of folks doing drugs, and that includes the pre-authorizations. You know, here in the States, you know, payers.
Payers themselves.
They're doing those pre-authorizations, again, maybe through their pharmacy folks, but
yeah,
there's 100 to 200 pre-authorization systems in a market like Oregon for drugs, rather than there's one.
Right, and the exception there may be if, you know, we have a non-resident patient, they're covered by insurance, right?
Yeah.
They're not sort of a beneficiary. I don't know if there'd be sort of a separate process for that, but we do find when we have non-resident patients with insurers that the insurers say, well, we'll cover this, or we'll cover that percentage of the overall bill, but we may not cover that, or yeah. So they do pick and choose a little more. Yeah.
Yeah, but I mean, I just
it's less.
To my colleagues that one of the administrative expenses in the United States is in a market like Oregon, you're dealing with 100 different drug pre-authorization processes, and they can all be different. They can all be covering some things, but not other things. Some of them are very transparent. Some of them are not at all transparent. And just imagine the time and expense saved if there's one. There's one source of all that. Yeah, okay.
Mary?
My question got back to dental. I'm just interested in what the Canadian plan, does it cover people for basic dental things if you're not, you know, employed by someone like you, or is dental just not part of it? Or
so if are you saying if someone is not sort of employed, like there's probably a gap there. If someone is sort of no fixed address or homeless, there's probably a very good chance that they won't have a dental plan. If someone is not, you know, not in the stage where they're working, like well, not quite that. For me, you know, I have two daughters. When they were kids, they would be covered under my employment plan. But when I stop working, I will probably have to arrange dental coverage myself, through a separate insurance, and maybe through Pacific Blue Cross, but I will be paying, my employer won't be paying at that point in time.
So my question is, I guess that in Canada, unless you are covered by an employer or private pay, dental is not part of the medical package that residents get.
That's true.
Okay, thank you.
Yeah, at least in British Columbia. I believe it's the same in other areas. And I'm not sure why dental is kind of different that way, but it just seems to be handled a bit differently.
It's different. Yeah, everywhere. It's kind of like teeth aren't part of the body, is, you know, kind of it's just the gestalt of it all, I think. You know, it started that way and has continued, and we're talking about having a dental coverage as part of our plan, which makes sense to people and is actually one of the incentives, I think, for people to think that, you know, maybe this wouldn't be such a bad thing. But anyway, I just, you know, okay, thank you. Just was clarifying.
Charlie?
So speaking of things that aren't covered, so dental is not covered. I guess pharmaceuticals, it sounds like are covered. My understanding is that in some provinces it's not, but I'm not sure if that's correct. And then another potential uncovered thing, at least in the US, is long-term care. And I'm wondering what about that in your province? I mean, apparently you have some facilities that are owned by the province, and some that are private. And so what's the coverage like for those things? So for pharmaceuticals, for long-term care, and anything else that would be healthcare that might not be covered. So
Yeah, so for pharmaceuticals, I think it depends on the medication and the prescription. Some things may be subsidized, some may be covered, but there are a lot of prescriptions that people do have to pay for on their own. I think there is some coverage for lower income individuals. And it's your medical expenses can be treated as a tax deduction to some degree to offset a little bit of the cost, but it's not a great deduction. So a fair bit of pharmaceuticals, I think people do pay on their own. Of course, if they're in the hospital getting treatment and not paying for those drugs, or if they're on something I mentioned before, HIV antiretrovirals or some really expensive medications, I don't imagine they would pay for those. I'm not an expert on sort of the pharmacare coverage. For long-term care, I can go into that in a little bit more detail. So there's a real mix. There's people who pay fully privately. I mentioned that there were some private long-term care providers that weren't funded at all through the health authority. For the ones that are sort of funded through the health authority or owned and operated by the health authority, there's kind of a qualification process, and we have long-term care assessors, nurses, who assess the patients who are trying to get placed into long-term care or who are at that sort of stage in their maybe a chronic illness or aging or whatever, where they're getting to a point where they need that care. But so if to sort of be entitled to subsidized care, you sort of have to meet a fairly high standard of need. I mean, at first, it's more like an independent living arrangement that you would get sort of assessed and said, you can still do some things on your own, but it would be good to be in a facility where there's people around and some of your day-to-day stuff is provided, like your food and, well, independent living. You might have the option to get meals or, cook yourself, but you're in a home. But as that sort of progresses, you go into intermediate care and extended care. And in those situations, you need to be in a facility with nursing provision. You'd have to sort of get assessed and qualify, and then you'd be entitled for sort of subsidy. And when you're entitled for subsidy, if you're either in a Vancouver Coastal Care operated home or another one that's publicly funded, you would have a co-payment that's based on your income. So if your income is, low, I'm trying to think of the percentage, I think it's 80% of your income, but up to a maximum of roughly 3,800 a month, I think was the latest. So if your income was really high, let's say you had a lot of investments or whatever, and your annual income from those investments put you in a high tax bracket. If you were in a subsidized home, you would only pay up to that sort of maximum monthly amount of $3,800. And we require people's sort of notice of assessment from their tax submission from the previous year submitted to sort of make that income assessment as to where on the scale they should be paying. Now, I mean, some people have a lot of resources, right? And their income from investments and retirement may be very high, and they may choose just to go to a private facility, right? A fully private facility where, you know, maybe $10,000 a month, they can swing it. But most people can't. But, you know, there may be people in that situation who are going into a private facility and aren't even bothering to sign up for something like that. My brother takes care of someone in that situation, and they pay about 10,000 a month Canadian. But for most people, they're trying to get into the subsidized system, I'd say, if they need that. And then it's based on that sort of 80% of your income up to a monthly maximum. Does that answer that question?
Yeah, it mostly does. So it sounds like the qualification is not based on income, but the amount it's based upon need, but the amount you pay is based on income. And is it also based in part on wealth, or is it just income that you get from your wealth?
It's income.
Okay.
Yeah. So
Thanks.
it's 80% of income, but they don't look at sort of trying to take any wealth. There's a probate fee upon passing, but there's not really an inheritance tax or any of that in Canada so far. So, you know, they don't tend to try and take the wealth away, that just or erode those assets for people just based off the income that's coming in. Yeah. Okay. I'm trying to think if there's anything else. There did seem to be some. Am I taking too much of your time?
No, we're
Okay.
still fine.
Okay. Charlie, you have another question?
I do. So how do you what's the process for setting or adjusting reimbursement rates for fee-for-service providers? And does that happen on a regular basis, or does it happen sort of as a needed basis, and who determines that? And so what is that process? And I guess a similar question for what's the process for determining a budget for a hospital or some facility that's paid on a budget? So I guess
Yeah. So the fee for service rates, we have a group called Medical Services Plan. They're part of the Ministry of Health. They're the ones that, you know, people are supposed to sign up with to be registered as a beneficiary. So you sign up with Medical Services Plan, but they also, I believe, are involved in negotiating the fee for service rates. And there's a huge sort of fee schedule. It's massive. But it's the process. So it's centrally negotiated, but it's flawed. And I'll tell you where it's flawed, is that I think in order to effectively change rates, if there's been, say, a medical advancement, for instance, in ophthalmology, where suddenly you can do eye surgery with laser technology in a fraction of the time where it used to be required. Right? You'd like to be able to sort of update those rates to sort of reflect that tremendous technological advance. But you need that physician group to agree to that rate update. So that that can be very difficult. So it is centrally negotiated, but it has, and if there's any ophthalmologists on the call, I'm sorry, I'm not trying to pick on you, but that's sort of a group here in BC that's known as, you know, if you really want to make money as a physician, for, you know, cardiac's good, neurosurgery is good, but the ophthalmologists are going to beat you every time because their fee-for-service rates are based on sort of what time it used to take. It doesn't take that time anymore. And so that's been a little bit of a sticky point. In terms, so I'll move on. I hope I haven't offended anybody. In terms of the setting of the hospital budget, so that would fall within Vancouver Coastal Health, and we own and operate the hospitals, or, you know, with the exception of the one that's operated by the ones that are operated by the Catholic group. I mean, we do have facilities in Canada called private hospitals, but they're usually like a long-term care home. So we have a long-term care home that's called such and such private hospital, but we wouldn't really consider it a hospital. It would be more of a long-term care home. So generally the hospitals are publicly operated, and we establish a budget for them as part of our internal operation. It's usually has a fair bit to do based on history. I'd like to say we zero-based budget every year, but that would be inaccurate. So we've often looked at sort of what's been spent in areas before. We may do what is it? Program-based marginal analysis, like PBMA, where we look at the sort of the, you know, the best place to spend the next dollar, or the least damaging place to reduce the next dollar. So we may do some of that sort of analysis, but a lot of the sort of budgets setting for the upcoming years is based on sort of, okay, this is what was done last year. These may be the expected changes in activity. These may be expected changes in input prices. You know, this will be the sort of the budget going forward. And so we also have, you know, it's the provincial government kind of determines our budget lifts, so what the increases are going to be, and our budget choices will be constrained within those increases. Often, so in terms of the province setting the budget across health authorities, they take a sort of blended approach between a population needs-based funding, so and sort of historical budget. So I'll give you an example. Vancouver is by far the largest city in British Columbia. And most of the larger health facilities were originally established in Vancouver. But the population in the Fraser Valley, the suburbs of Vancouver, has exploded. It's growing at a rate much faster than within the core of Vancouver itself, partly because of cost. It's a lot cheaper to live in the suburbs than it is to live right in Vancouver City. It's a very expensive city. And so the suburbs population is growing faster, but they haven't had as much sort of health infrastructure there in the past. It's getting built. There's a new hospital going into the suburbs under construction now. But if you looked on sort of a per capita basis, they'd probably say, well, there's more funding that was going to Vancouver than was going to the suburbs of Vancouver, even though now the population in the suburbs has kind of exceeded that right in the core city. So they've done studies and they've looked and said, well, really, Vancouver Coastal Health should have quite a bit of money taken away, and that should be redistributed across the rest of the province. But to do that, I mean, you know, it's easier to say, but you've got a big hospital facility here. You don't have that here to the same degree. You've got sort of specialist surgeons and other arrangements in place here. So it's not just, hey, it's easy to lift. We're just going to take 200 million out of there and put it over here. So what they've tended to do is they've tried to make the increases for those faster growing areas a higher percent than maybe the increases that we would get in our budget lists. And so they're trying to sort of reflect over time the faster growing populations through a population needs-based funding model without just doing a dramatic lift and shift, which is so difficult when a lot of the expenditure is heavily facility based, right? So they're gradually sort of increasing those other budgets more, but they're also taking into consideration people may, like me, may go into a Vancouver Coastal Health facility, but I live in the suburbs. Well, they look at sort of those cross health authority flows, and they also take into account sort of provincial specialization. So, if you're in the north of BC and you need very specialized, like I said, spine care or whatever, you're coming down to Vancouver and you're going to get services there. They're not gonna start a spine unit in Prince George, which has a population of 100,000 or so, when the lower mainland here has 2.4 million people, and that's where most of the spine stuff is going to be done. It's just sort of the way it. So does that answer a little bit about how they sort of look at setting the budgets? But yeah, but it's they're tightening. The mandate letter to the Minister of Health is to sort of tighten up costs, especially around administration. So where sort of things were a little bit more of a free for all during the pandemic, it's back to less free for all. Cheryl?
You may have other topics you want to cover, but I do want to make sure that we cover all of the administrative cost topics that we wanted to discuss today.
Oh, that's good.
Could you say a little more about tightening administrative costs, like really specific as to what you're looking at reducing? Because it looks like you have a pretty lean administrative costs, and I find that difficult to consider, further tightening in administrative costs in your model.
Yeah, I can probably speak a little bit to that. So, but it's during the past fiscal year, we were asked to sort of hold administrative hiring, or all administrative hiring would need approval from actually the CEO. So if someone left to go to another area, this didn't apply to clinical, right? So clinical is clinical, and if there's needs there, you hired them. But if there was a vacancy that came up, whether through attrition or whatever, or retirement, in a corporate area, then it was up to a decision. You'd request, if you're trying to fill that position, you'd request from the CEO, but the CEO may not approve, or you may be directed to hold vacancies. I mean, we're going to look, our biggest area of admin and support spend is on systems. So, and we find the systems costs are very expensive. I'm not an expert on how to cut systems costs. Our financial planning teams deal more with sort of setting the budgets and monitoring variances. We have gone to sort of a little bit of a shared service where Provincial Health Services Authority runs our IMITS system for us, for themselves, and for Providence Healthcare, the Catholic group. But I'm expecting there will probably, just because of the size of that area, there will probably be some focus on it. I think there will also be some focus on sort of areas that might have been put in for sort of political culture change. So we have teams within our communications group related to things like DEI, anti-racism, and those are good. Those are good things. Don't get me wrong, but are they? If there's sort of underspend in those areas, there's probably a risk that they might be reduced. Yeah, those are some of the areas. We do think, depending on how much we're expected to reduce, it may have to go into clinical. It may go to looking at our contracts and seeing whether there's contracts that aren't adding as much value, or enforcing health authorities that aren't at the 10% admin and support level down to 10%. We're at Vancouver Coastal Health, I think we're at 10.37. So we're a little bit over the ministry's target. Maybe they'll come back to us and say, you got to squeeze that. But they have sort of a percentage for each health authority. They know one of the health authorities is operating at 15%. That one has got an administrative review happening. Our past board chair was put over as their acting CEO with the intention of shaving costs in that area. And then there will be an admin review that comes out to other health authorities, probably in terms of, in order of how high their admin and percent spend is over the 10%. Richard.
Yeah, thank you, Don. As you know, we're trying to build a single payer plan in Oregon. And the biggest single area that we still have controversy about is how much providers spend on billing, because they have to negotiate their rates with each provider, with each of multiple insurance companies, and then they have to bill for that. And so we have a pretty good sense on the payer side, how much payers spend in order to administrate that billing, but we don't have a good idea of what providers pay in the United States to do that billing. That's somewhere on the order of 10 to even 25% of the receipts of that clinic. So then there's the hospital side, and then there's the clinic side or physician office. I'm using those interchangeably. So
Yeah.
Do you have, and since you manage the hospitals too, I think you have a very good sense of what you spend on billing. Can you give us an idea of what private offices that bill on a fee-for-service basis to the province, what they would spend on billing?
That one I would have
Okay.
to try and reach out to my counterparts, because
Yeah.
I don't know. I don't see what flows through the private offices, but they do. A lot of them would have a contract in place with a billing organization, I would expect. So,
But we can say that for any given procedure they do,
yeah,
how many different organizations would they be billing? Just you?
they would, if the person is a beneficiary, they would be billing us. If they have, if they're providing services within our facility, yes, but they, for people who aren't beneficiaries, they may bill those individuals or their insurers directly. But for beneficiaries, they would be billing us.
So they just bill for beneficiaries, they just bill one agency, your agency. And then the second thing is the price list. If they're, regardless of whether they're billing your agency or some other agency, basically there's just one price for a given procedure. Is that correct?
That, again, that is correct for beneficiaries. If it's on a fee-for-service basis, yes, they're following that model. If someone is a non-resident,
yeah, there
may be a different billing setup or schedule involved. We have for our beneficiaries, like if someone comes into the hospital, like I said, they'll get services, beneficiaries not pay. Uninsured residents, we bill at what's called an interprovincial rate. It's calculated by a Canadian sort of overall governance group. There's a group called the Canadian Institute for Health Information, and they have a subcommittee that looks across each hospital in Canada and sort of comes up with some interprovincial rates for that hospital that provinces can bill each other if, one of their residents goes to, I don't know, Kelowna General or something here in the interior of BC. There's a rate for that hospital that's used for interprovincial billing. And that's determined by that sort of central Canadian group. For non-residents, each province can kind of sets its own rates. It's usually about 2.5 times what's the interprovincial rate calculated. So it certainly has a markup. There are some things that aren't included in the interprovincial rate, like the cost of facilities and physician costs, but yeah, the non-resident rate is about 2.5 times what the interprovincial rate would be. Does that get, I wasn't able to fully answer your question, but
That's good.
hopefully
Thank
that gives you a little bit of information. We do have people who sort of specialize in the physician compensation piece. And so my co-executive director, and there's a actual physician relations and compensation team who could probably answer those types of questions a lot more knowledgeably than I can. Yeah, but hopefully it gives some information. I'm not sure whose hand was up first, but we'll go with Mary and then to Cheryl.
Thank you. When you talk about beneficiaries, those are the people who live in your province and have signed up or whatever.
And signed up.
And then when you talk though about like uninsured residents or the people who are, if I came up to visit, what I would be if I ended up in one of your hospitals, but what is your basic percentage of people that you consider beneficiaries that are in BC or wherever that?
Oh, I'd say I don't have the exact numbers, but I'd say it's well over 90%.
Okay.
Probably 95%. I mean, I think it's uninsured residents. I mentioned the homeless and NFA,
Yeah.
but it can also include people like people here on a work visa, people here on a student visa. We also had, there are some programs for refugee coverage, a little bit more administered by, they get services from our facilities, but their program is more sort of administered by federal government. So that, those are categories that would be sort of fall into uninsured resident as well.
That pretty much answers, I guess what I'm saying is when you're talking about these kind of billings or you're doing whatever, it's a really very small percentage.
It is a much
the
smaller
action.
percentage. Yeah,
And so
for
you're
sure.
talking the majority of people who come
Yeah.
in are under these other payment mechanisms that you've, kind of got. And so
For sure.
when
For
they're
sure.
talking, doing billing, with contracting with somebody to do it, it's probably a very small number in their practice.
Well, and our billing is done through another health authority, so we sort of outsource that. So yes, we have kind of a
Yes.
contract for it, but it's not a contract with a private for-profit organization.
Right.
It's a contract with another health organization where we just try to
Yeah.
combine the staff to have some sort of economies of scale.
Right. And
Yeah.
so what we're worried and and what we're trying to get rid of is what I think John alluded to earlier, that not only with, pre-authorizations for pharmaceuticals, but for billing, X code, it goes off to, 100 different insurance companies or, maybe not quite that many, but it's very complicated. Whereas the majority of the providers that work in British Columbia, their billing is kind of one, it's simple. It goes to one place. They don't have to call and figure out, different systems, et cetera. So that's just 95 or 90 to 95. That's what I was after. Thank you.
Okay, yeah, there's all sorts of interesting nuances. So there is one group in particular, I'll just touch on this quickly, where we had sort of a different billing arrangements, non-resident group. It's particularly birth tourism. I don't know if that was a thing in Oregon, but in Canada, citizenship status could be based on the location of birth. So if you're born in Canada, you get Canadian citizenship. Well, gee, that's appealing. Maybe we'll fly over to have our baby. So there was more sort of pre-COVID that we'd have birth tourism. And there were actual organizations that were marketing, come to Canada, have your baby have, your baby will have citizenship. And so for those situations, so the thing with maternity, it's coming. And so we would charge sort of an advance, a deposit in advance to sort of cover the cost that was anticipated, depending on whether it was likely to be a natural birth or a C-section. And usually that deposit would cover the cost of the maternity billing unless something went wrong. If there were complications, then the deposit wouldn't cover, we would be trying to collect. The worst case scenario, there was a situation where someone unfortunately had a baby with severe birth defects and decided that they didn't want the baby. And that baby became essentially, what did they call, ward of the state or ward of the province. We've only had sort of one situation of that, but yeah. So that's just sort of a unique thing. Okay, Cheryl.
Well, Mary Lou had my exact questions. I don't really have a question anymore. I just want to say that we have 5 minutes left of Dawn's time. And so John may have the last question and comment. But I do want to also mention in my review of the task force recommendations on administrative costs, the one area that I'm seeing that we haven't discussed today, and really isn't a question for Dawn because it's not a Canadian issue, and that is we added in admin costs for winding down existing healthcare plans, federal reporting and operational requirements that we need to transition our existing healthcare system into this health plan. And luckily for Canadians, you don't have to do that. So that isn't a question for you. I just want to mention that to the committee because we are going to have to grapple with that part too. So with that, I'll leave it to John to ask the last question.
Well, I'm sorry, I can't resist saying, who knows, Don, when we take over Canada, maybe you'll have that situation.
We'll see what happens. We'll see what happens.
Yeah.
Or better yet, that they take over us. Yeah, okay,
that's not gonna happen. That I'm confident of.
Good,
Yeah.
good. Mainly, I wanted to make a comment to colleagues. I think actually the experience that Don is describing in Canada could provide a very relevant estimate on one side, if you will, in terms of provider admin costs. Because what he has described is they cover all residents. I would imagine that 90% of most providers' incomes in our scheme would come from the single payer. So getting some sense of what that cost is would be helpful. The only example we kind of have of that in the United States would be Kaiser-like organizations, where their physicians are all focused on one organization for the most part. And who knows to what degree Kaiser would share their estimates of what their admin costs are compared to a multi-specialty clinic that is dealing with hundreds of insurance companies. But I'm impressed listening that if and when, and I'm pulling my hair for the day when we start to talk to people actually in Oregon who know about administrative costs for providers. The kind of estimates that Don has talked about would be relevant, I think. So just wanted to make that comment.
Anything, Don, that you have to add as a response or another comment before we let you go?
No, just thanks very much for having me. It's been a pleasure. I'll try and look up some of the questions that came up a little bit. I am in the middle of year end, so it might take me a little bit of time, but Cheryl, feel free to reach out if you have, or Charlie, or whoever, if you do have any sort of follow-up stuff, I will try and take a look at it. But I wish you, I hope it was helpful, and if you do have follow-up questions for me, just let me know.
Yes, absolutely. Thank you so much for your time and expertise, Don, and
Thank you.
we'll probably take you up on that.
Okay.
And feel free
Thank you,
to send
Don.
any follow-up from those questions to Mimi or myself, or both of us. That's fine.
Sure.
Thank
Will
you so
do.
much,
Thanks. Have a
Don.
great rest
We'll
of your day.
appreciate it. You too.
Okay. Bye now.
Bye, Don. And so with that, we'll take a 10-minute break. We'll start again at 10:55 with our new consultants, Echo Northwest, and hear what they're going to be helping us with. And maybe they'll have some feedback. Well, I don't know if they've joined us yet, come to think of it. Okay. All right. Well, so have a nice break, get some stretching in or coffee or whatever, and then come back at 10:55. Thanks. Okay, we're back. So now we're going to move into learning about the scope of work of our consulting firm Echo Northwest and their first assignments. And so I'm just going to turn it over to Kim Yee, our senior policy advisor, to facilitate this particular agenda item. So thanks, Kim.
Thanks, Cheryl. Hi, everyone. Nice to see everybody again. And Kim Yee. We are excited now that our new executive director, Mimi McDonald, has joined, and Mary Lou Henrich has joined from the board. Our committee is feeling really well staffed and ready to support Cheryl in all of your work. I'm really excited to formally introduce our consultants from Echo Northwest. This team's going to consist of Morgan Shook and Andrew Dyke. Morgan is actually on spring break today, so Andrew is going to be holding down the ship. But I want to start by first sharing a graphic that compares the tasks that the Finance and Revenue Committee was chartered to work on, as well as the tasks that Echo Northwest is specifically contracted to conduct and complete. And I'm sitting in as the project's contract administrator. So while we have this portion of the conversation, you are welcome to ask questions of Echo Northwest, Andrew from Echo Northwest, and of Cheryl and Mimi and me. However, if I feel that any of the requested work is stepping over their contracted scope of work, I may interject and make sure that we keep everybody within the boundaries that have been established by the contract. So I'm going to share my screen now. So again, this policy, we're going to review Echo Northwest scope of work. Our two consultants from Echo Northwest are Morgan Shook and Andrew Dyke. And Morgan is absent today, but we have already reviewed what's going to be covered together. So this is not going to be surprising to them. Okay, I'm going to hopefully make this large. Okay. Cheryl, are you able to see the text on the screen okay?
Yes.
Thanks for nodding. Okay. This was also shared as an attachment for this meeting. So if you're unable to read this on screen very easily, you can also refer to the attachment that Katie sent out last week. Okay, so this graphic shows the tasks that the Finance and Revenue Committee has listed in their charter in blue on the left panel, And then the two rightmost panels are the tasks that Echo Northwest is contracted to complete. So what this graphic shows is sort of how the work that the Finance and Revenue Committee has been working on is going to feed into the tasks that Echo Northwest is going to be completing. What I also want to point out is that there are deadlines for certain deliverables from Echo Northwest. So the first two sets of deadlines are going to be that with the second box down, which reads with Finance and Revenue, with F&R, Echo Northwest is going to identify how much revenue needs to be raised to fund the Universal Health Plan in Oregon. And by the end of May, we'll be seeing those deliverables from Echo Northwest. And then the fifth box down, Echo Northwest will identify potential taxation and revenue sources and a financing structure. And then, of course, the first box on the rightmost panel says, Echo Northwest will provide revenue and taxation options to the Finance and Revenue Committee regarding raising the revenue needed to fund the UHP in Oregon. So those three tasks are due by the end of May. Cheryl, I'm going to let you weigh in a little bit because the Finance and Revenue Committee tasks were chartered to end by September of this year, but we can see that Echo Northwest contracted tasks will actually last through the end of December, mid-December, when Echo Northwest is going to share a finalized report with iteration from this committee and board members about the estimates for creating these different revenue options. And so, Cheryl, we've spoken with Echo Northwest and with Mimi about this, but briefly, and Cheryl, please correct me if I'm stating this incorrectly, but briefly, the board is going to be conducting a big strategic planning meeting in May, and part of that is going to be to revisit all of the different committee timelines and make sure that the different work streams fit together. So if you're a little bit concerned or confused about the difference between this committee's September deadlines and then Echo Northwest December deadlines, please feel free to pipe up now, and maybe Cheryl, you can address that, or Mimi can address that.
I just would say, I'm just trying to figure out whether it's realistic that the committee is done with its work in September. And given the fact that you have as a deliverable that Echo Northwest will refine the initial taxation options, et cetera, in October with Finance and Revenue, it makes me think that maybe we will need to meet into the fall with our committee. Whether we need more meetings besides once a month, I don't know yet. I think that's something I'd like to hear from the committee members, given the tasks before us and the contracted tasks of Echo Northwest.
Thanks, Cheryl. So I do see some hands up, and Cheryl, if it's okay, I'll let you moderate this part of the discussion.
Sure. Okay.
But thanks.
Right.
So I do want to say that we do have Andrew here from Echo Northwest, and so if you wanted to also direct any of your questions toward Andrew, that would be welcome. Okay, Cheryl, turn it back to you. Thank you.
Let's go with Richard first.
Yeah, I'm looking at the slide and trying to get an idea of the timing here. So up at the top, it says, in the middle column, it says identify current sources of healthcare funding in Oregon. You mean different from taxation? That's one question. And then number two is, I think the biggest single task that faces this committee on the revenue side is what is the exact mix of taxes? And by exact, I mean to the nearest $5 billion. What kind of a taxing setup would we need to meet what we know, or we have pretty well, because of Charlie's great work, we have a pretty good idea what we're going to spend. But we really need to get going on what's the set of taxes at what rates for what individuals in Oregon is going to pay for this? And is that due by the end of May, or is that due in July? So I'm just going back and forth between July and April and May, and then looking in the right-hand column that the revenue and taxation options need to be done to us by April and May.
Andrew, I'm not going to put you on the spot here. This is Kim. I can actually take this on. So thank you so much, Richard. Totally get your confusion there. The April-May is sort of a partial, the April-May block that you're seeing on the rightmost panel is sort of a partial amount of the work that needs to be done. So you're right that even though that July panel at the top is feeding into the April-May piece, the April-May, that rightmost panel is cascading all the way down to the final report that's due. The interim report is going to be due in October, and then the final report is going to be due in December. So maybe I can do the graphic better. We are already laughing about my terrible graphic design skills, but I would see it as July is feeding down through the arrows to that October-December report, and the April-May is sort of like the interim piece of it. So it doesn't need to be finalized by July, but it needs to be finalized certainly by October and December.
So Kim, what I'm
Does
trying
that help
to
at all?
idea of in terms of preliminary and final.
Yeah.
Well, how much is in the preliminary? I mean, what we're really facing is hugely high taxes, either on income or payroll or both, to pay for this. And we really got to get going on who are the groups that are going to pay for this, and start to seeing if it's even doable, because we got to get ready for the reaching out to the citizens. So by the end of May, will we have an idea of what rates at what income levels apply, or is that coming in October?
Thank you. So I think that Andrew is actually going to be well suited to answer this one. Echo Northwest has done a lot of work for other states for very analogous projects here, and so they're not starting from zero. And certainly I know Andrew and Morgan have watched all of this committee's videos, read all of our materials. They're well read on what this committee has done already. And so maybe Andrew, if I could have you speak just a little bit about Echo Northwest's expertise and how you and Morgan have already stared addressing this particular piece, that might help Richard understand.
Happy to do what I can.
And
so I think I believe the committee's been introduced to us, but just very briefly, I'm an economist focused on public finance and labor in grad school. But in my almost 20-year consulting career at Echo Northwest, public policy consultancy based in Portland. I've worked on sort of healthcare issues from a number of different perspectives, from working with state administrative Medicaid databases to working with providers, with insurers, et cetera, on various aspects of healthcare policy. My colleague Morgan, who is traveling for spring break, unfortunately he can't be here today, also has a lot of experience. Both of us have broader experience in terms of assessing revenue options, revenue potential for revenue sources across the spectrum, and then as part of our scope of work here, assessing the implications of the distributional effects of changing taxes in each of those domains. So a lot of experience working with public and private sector entities. Morgan, for example, a couple of years ago finished working with Washington's tax structure working group, which was a big reset of Washington's tax structure. And, we have the expertise to support committees move through these kinds of questions. And our goal is not to reinvent the wheel or to question anything that's been done, but really to add to the conversation. So I think specific to the questions here, I think sort of this workflow is designed to sort of jumpstart the iteration process. You don't want to ask us a question and have us go away for 3 months and then come back and say, here's the answer, because we need input from you. We need to iterate. And so I think the earlier sort of April, May deadlines will provide, sort of a first menu of options, first set of assumptions and estimates. And then we work from there towards the, July deliveries and ultimately the final reports further down the road. So happy to answer more questions. I'm not sure if that clarified things, but that's my take on that.
Did that answer your question, Richard, or do you have a follow-up for Andrew?
Good for now. Thank you.
Okay. Charlie.
So I just want to point out that we are in our April meeting. And so And we have not yet begun to discuss the nature of the tax system. I mean, I presented some information with questions, but we have no discussion about those questions and what the nature is. So I would say that we have a lot of work to do, and I can't imagine that we're going to get very far along with the nature of the tax structure and possible rates by May. And another point I would like to make is that my notion of what needs to happen after we provide some preliminary notions of what the tax could look like is we need to go out to the public and get some feedback and then have a lot more discussions based upon public feedback. And so I can't imagine that that's going to happen before September. And so it seems like there's a whole lot of work to be done after September by this committee. And so I just want to make that thought known. So, yeah.
Thanks, Charlie. Any comments from Andrew or Kim on that, on Charlie's comment?
Let me just quick follow up. Agreed on the amount of work that needs to be done, and I'd say that this proposed workflow, I'm not going to opine on whether it's feasible or not, but is contingent on other things that the subcommittees and the committee are doing with respect to the plan development. And so, you know, if the timeline were to stretch out, I think the same tasks certainly apply. It just stretches out, you know, the timeline that we need to do our work as well.
Just real quick, and maybe this isn't something you can answer right now, but just to Charlie's comment that we need to act, I think, Charlie, you were the one who said it, that we need to reach out to Oregonians and ask them some questions about this, you know, give them kind of a first draft, so to speak, to react to. When do you see that happening in this timeline? Because I do agree, we have to check and see if our fellow Oregonians are supportive of our ideas. Do we have that in the timeline?
This is Kim. Yeah, Cheryl, thank you. This is Kim. Mimi and I just met with our communications committee chairs, Amy Glass and Amy Fellows and Michelle Glass. And they were also stating that there are certain limits that the board has agreed on what the communications committee is in charge of in terms of outreach to the broader set of people living in Oregon. And based on that, there are specific groups that, based on the Joint Task Force report, that the communications committee is going to be conducting specific outreach with. And so those will include, say, tribal liaisons and tribal groups, but it's not meant to target, that communications effort that you're speaking about, Cheryl, is not meant to target everyone in Oregon. And within the scope of this particular contract, Echo Northwest is not responsible for doing that committee outreach. The communications committee is responsible for doing that outreach, and or at least a portion of that outreach. So hopefully that answers your question. I know it's not satisfying, but it certainly speaks to the fact that the different committees are supposed to be tied in together, and the communications committee has sort of laid out a plan for how they can share talking points and communications efforts with the various committees. So finance and revenue, plan, design and expenditures, operations, all of those committees, you're right, do need a concerted plan for how we talk about the UHP going forward.
I wish Chunwei were here, but I want to speak to his citizen jury idea, and hopefully we can talk with the communications committee a bit more about that and figure out whether it's in the budget. Maybe this is a May discussion of the board, so I just want to put a pin in that. John.
Yeah, well, I agree with Charlie and Richard. I'm a bit stunned by this discussion. I would remind folks that the last committee that continues to meet at the legislature until near the very end is Ways and Means. And I'm scratching my head to hear that this committee will disappear. long before we're anywhere close to a final model, if you will. So that's number one. Number two, I continue to just scratch my head trying to figure out, why are we obsessed with taxes when we still haven't agreed on what the plan's going to cover for who? We've been through this in the task force. If the board wants to cover long-term care, we're going to need more than $17 billion. If the board wants to cover workers' comp, we're going to have to take over the workers' comp revenue system. If the board wants to cover public health, we're going to have to figure out how to get that funding stream from the legislature to the single payer. We've been told, well, that will all be decided. But, we're not hearing that. Those types of things make billions of dollars of difference. The discussion we just had, I know from the task force, if we're moderate in terms of administrative expense, there's $4 billion of savings that the task force left on the table. There's a big difference between 17 billion and 13 billion. I personally feel the task force left money, at least $1 billion in terms of administrative expense at the payer level. Now we got 5 billion. Now we're down to 12 billion. I firmly believe that there are other ways to get that down to probably 10 billion. So we'd be talking about 10 billion in taxes rather than 17. Why aren't we focusing on that? Well, we've been told, well, somebody else is involved with administrative expenses and somebody else is involved with these other sorts of things. Andrew, welcome. We badly need you. My impression was we would begin to see a model emerge. And that model would help decision makers, especially the board, to realize, okay, here's the most aggressive approach to administrative expense. Here's the least aggressive. Here's the middle. Here's what happens depending on what approach you choose in terms of the taxes that are going to need to be raised. The homework assignment prompted me to look at Table 8 in the task force report, the Table 8 in the actuarial Optimus report. Please, everybody, look at Table 8, because Table 8 shows how much money starts to move around in the task force model, primarily because of the normalization of reimbursement. Billions of dollars are moving around. Look what happens with the, quote, employer contribution. It goes down $5 billion. I just don't understand why we're not doing our very best. Every business I know would do their very best to reduce costs before they raise taxes. And so to hear that, as Charlie said, this is our April meeting. Almost all the additional meetings that we had agreed to, at least in 2025, were canceled. And now we hear we need to make decisions by May, and that will be done in September or October. Mimi, you have a tough job. So I'm concerned.
Good points, John. And I wonder, Mimi, if you want to speak to those concerns, or so I'll call on you first, and then if Kim or Andrew, if you want to address those points from John, please go ahead too.
Yes, thank you so much. Yes, certainly thanks to everyone for bringing up those points and the concerns about the timeline. I think, and again, this is week 2, but I have done a lot of research into it. And I think that, the essential dilemma that we all are trying to deal with is the fact that this work is going on in parallel and is not sequential. And so, which when things are happening in that sort of parallel thing, one half of the equation being, what are the services, how much is it going to cost? The other half is, how on earth are we going to pay for it? And it has not worked out, or was not initially planned. The answer to one half of the side is going to be there in time. So I think from what I understand, and I think what I am really beginning to appreciate, is that with, excuse me, with our consultant groups and with Echo Northwest, what they will be able to provide this committee and the larger board are those very specifics that people are requesting, in addition to sort of multiple scenarios. And so as things are moving on and sort of multiple potential cases of when it comes down to determining the total need. And so I believe, and certainly from what I understand, is building on all the work that's already been done. So they're certainly not starting de novo. And I don't need to speak for you, Andrew, but just from our conversations, that clearly is what's going to happen. Regarding the decision process, and perhaps Cheryl, you can help me with this. It's my understanding, of course, that there's not necessarily a committee final decision due in April and May. However, according to what's going to be the deliverables, is that there will be these options presented to this committee. And so then there will be sort of a sense of, yes, this seems appropriate, we're going to move forward with this, or no, we need to either gather more information or choose a different path. So I feel that, at least again, from my side, it is that conundrum of having to work on in 2 parallel processes that makes it feel like the finish line is very, very far away. But from the amount of work that actually has been done and is about, and especially is going to kick up, I think that those 2 are going to convene and be synergistic and help provide some answers. So that was a little long-winded, apologies.
I just want to respond to you, Mimi, on one thing, and just channeling Helen. This committee wouldn't make decisions, but we would come up with recommendations.
Apologies, thank you.
And the thing that I'm concerned, and I'm just pretty laser focused on the timeline right now, and I am a little concerned that our meetings now, I'm starting in May, I think, are just like 2 days before the board meeting. So we'll never be able to bring to the board a recommendation that we come up with in that month that will have to go to the next month. So I'm concerned about that there's going to be a lag time of a month. So I think that's a problem that we need to work out, just as one of the problems to work out. Yeah. So Kim and or Andrew, do you have any feedback or response to the concerns John raised?
Yeah, just a quick follow-up to, I mean, totally appropriate concerns, and I very much sympathize with them, but just to underscore some of what Mimi said. One, yes, our role as consultants is to build on the prior work, but I think, John, you would say there's a lot of work yet to be done, which is a fair point. But I think the key point in what Mimi said was we do have parallel work streams. They move at different, it's jumps and fits and starts. And what we are hoping to do is help this committee move the conversation forward as quickly as possible to meet the goals and the timelines that are out there. And I think that's, whether it's April, May, or whether the timeline slips a little bit based on what's on the slide, we need to start somewhere. For example, we know that this is not a $1 billion problem. It's not a $2 billion problem. Is it 10 billion? Is it 17 billion? We don't know yet, but we need to start looking at, we know there need to be revenue sources that raise a lot of money, whether it's payroll, whether it's income, whether it's something else. We can start to investigate those and to put some bounds on, what might be possible, whether it's political viability, economic viability, considering the distributional impacts, to start providing some parameters in inputs to, again, move the conversation forward on the revenue side without necessarily needing the final plan structure or a specific target, which will inevitably come with ranges in any case.
Thanks, Andrew. Okay, Mary Lou.
This is my first real meeting. I have watched some of the past ones, but not all of them. I guess I just want to second what John is saying. Makes a lot of sense to me, that there is, I don't know, I'm just a bit overwhelmed. Honestly, this process of, kind of what the contract, how long it goes, who's doing what. I'm just feeling a bit overwhelmed with all of it and feeling like rushing, it can't possibly be done in my mind by September. I mean, I think I'm kind of going, what? I missed that in the details when I said I would sign up for this committee. I assumed it was going on, much longer, and I'm dedicated and willing to be part of that. But anyway, I guess I'll stop. I'm just kind of feeling overwhelmed.
Thanks, Mary Lou. John?
Well, with all due respect, I think we do know the Optimus model was about $17 billion in taxes to be raised. And there were, pros and cons of the Optimus model. But, they made, the task force made a variety of decisions. They decided, for example, we will not cover out-of-state employees. That was a $1.7 billion decision, if I recall correctly. Medicare folks will all be required to purchase Part B coverage. I think that was $1 billion decision. We won't cover workers' comp. We won't cover long-term care. We won't do public health. And I would say, I know that there's concern about task force decisions, but given the timeline, the only way this is doable is to build the model using Optimus and acknowledge that it's an imperfect model, but it will allow folks to see what the impact is of their decisions, which I frankly am getting the feeling has been lacking here. I was very disappointed when I realized that the task force had not purchased from Optimus the model, so that we could start with something and start to play around with it. I mean, every financial task I've ever been involved in began with a model, perhaps crude, and then built on that. Andrew, I hope you all would consider that, because if it's not well known, I think the task force knew that $17 billion was not doable, and there are a variety of issues we weren't certain of. For example, even in that 17 billion, well, wait a minute, the public already covers by taxes healthcare for public employees, city, county, state, TriMet, Metro. Is it going to count that these taxes would replace those old taxes, and we get, i.e., some credit for that? You follow me? That's a discussion that we never fully pursued. If in my mind, for me to be comfortable we're going to need a model. We're going to need it soon. You know, I hope you'll consider that. And the other issue is we still don't have an actuarial firm. I know one's been chosen and the relationship is being negotiated, and they're very competent and capable. Oh my gosh, you know, that's another reason if there's going to be a delay with them, start with Optimus.
Andrew, do you have thanks, John. Do you have any thoughts about, or anything you want to express about the model?
Well, just I agree. I mean, modeling is I mean, it's central to what we're doing, what you know the actuary will be doing, and certainly do need to be doing that. I think you know we are now fully up to speed in terms of the committee's activities, and you know, to the best of our ability, we'll be following the guidance from the committee and answering the questions that are posed.
Thanks, Andrew. Charlie?
I would counter a little bit of what John just said about starting with Optimus. I mean, we do have a little more information. I mean, I provided a bit more detail about expenditures. So we have some I would say newer or more detailed information about expenditures and what we might need to replace. And the model, the taxation model that Optimus put forward, I don't think we want to use. So it we should be talking about that very soon, about what notions we would like to see in a tax structure, hopefully the next meeting. And I will provide, I think, some more detailed information about what my thoughts are related to that as a starting point for discussion. So we'll see what happens with that. But we do need to discuss that really soon, what our taxation model should look like. And how much we need to spend is going to be a really big question. And I would point out that there's some assumptions that were made in the Optimus report that are pretty questionable, relating to potential extra money from the federal government, especially, I would say. I'll stop at that.
Yeah, especially now. Thanks, Charlie. So it seems like we're kind of moving into meeting reflections and next meeting topics. Unless, Andrew, I just want to invite you to say anything more about your scope of work that you want to. But I do think we're starting to think about what it is we need to cover very soon in these committee meetings. And then I would venture to suggest that maybe we need more meetings. I mean, it's hard for me to suggest that because I'm in the middle of legislative sessions. So it's a really difficult time for me professionally, I would say. So I'm not saying that lightly. I'm just putting it out there as maybe a need. So, Richard?
Yeah, in terms of what are the differences in duties of the actuarial firm with respect to tax at various levels for various individuals and small businesses versus what Echo Northwest will do? What's the difference there? What's the dividing line of who does what?
So I think the difference is in terms of what we're working with. We would turn to the actuaries to take a plan, for example, and look at all the caseload information, every assumptions, et cetera, project out costs, and then we would take that as and turn to the whatever the decisions the committee has decided about the general structure of the taxes that are going to fund this, and figure out what mix of those taxes would reach that number as determined by the actuaries.
I thought that's what Echo Northwest is going to do in April and May, of the mix of taxes of employer payroll and income tax.
Richard and Andrew, this is Kim. I'll step in. We are finalizing that contract with the actuarial firm. So we haven't come to a final agreement on what services they're going to perform, but we are being careful to make sure that they don't overlap or take away from the work that Echo Northwest is doing. I will be able to share and I understand that folks feel frustrated about the timeline, but we are finalizing that contract now. I will be able to share an even bigger overlay of what the two groups will be doing. Echo Northwest is focusing on the work that the Finance and Revenue Committee is doing, whereas the larger, the contract with the actuarial firm is going to be touching on work that that Finance and Revenue, Operations, Transition Planning, and Plan Design and Expenditure are doing. So it's a much more expansive contract. So Richard and everyone else in this committee, hold tight. I will share that scope of work and how it overlaps or doesn't overlap, excuse me, with Echo Northwest as soon as I can. We did have a delay because we needed to hire Mimi. We needed to hire our executive director. So we couldn't sign off on any work until we had a Mimi in play. So please try to remain patient. I will share that as soon as I can.
So Kim, is this something that you could go over at our next committee meeting, maybe? Is that
Definitely
the time?
Yeah, yes, our procurement specialist is working on writing the draft of the contract now. She'll get that to Mimi and me as soon as possible, and then Helen and Mimi and I will be able to review it and then finalize it. So thank you everyone for your patience. I know that I liken this to an elephant, and Finance and Revenue only gets to see a small part of the elephant, unfortunately. And what I wish is that everyone got to see the whole elephant, because, you know, I heard John's frustration about why are we putting one piece, the Finance and Revenue piece, before the Plan Design and Expenditure piece. And Cheryl, you're totally right. It's happening in tandem, but Helen, the board chair, explained that way early in the board's strategic processes, they decided that Finance and Revenue would be coming up with their initial plan before Plan Design and Expenditures was. And Mary Lou, who's our board member, who's in both committees, is privy to the discussions now that's happening across both committees, and very few people are, unfortunately. That small group of people includes Mimi, me, Helen, and Mary Lou, unfortunately, are the rare people who are privy to everything that's happening across all of the committees. So thank you everyone for your patience. Thanks for your participation, Cheryl, and giving it back to you.
So could we talk about then what we can expect from Echo Northwest to present to us at the next committee meeting? Or I would say present in advance maybe, and then we discuss at the committee meeting to see if how we view the proposal perhaps, or what can we expect? So we're building an agenda for the next meeting. Do we need a meeting in between to discuss like a draft, or do we just wait until the May meeting that's scheduled? I can't remember what date that is. Do you need that amount of time to develop you know, the first deliverables that were
I don't want to speak over you, Andrew, but I will say that given the deadline that we've asked of Echo Northwest, it is legally, we cannot push that deadline up earlier to them. We cannot say, oh, you need to give this to us by end of April. However, Cheryl, you and Mimi and I have weekly planning meetings, and Echo Northwest is wonderfully communicative. And so if it is the case where Echo Northwest, where Morgan and Andrew are able to provide us some interim deliverables that we're able to review, certainly within the public records postings rules, we need to have those to this committee at least a week beforehand, so that the committee has ample time to review and the public has ample time to review. We will do our best, and I don't want to force Echo Northwest to move faster than we've asked them to contractually, but we will do our best, and we will be in, you know, really good weekly communication about what's happening on everyone's ends.
And all I'll add is that we will also do our best. And I think obviously some follow-up post-meeting here, communications, we'll discuss you know, what can happen and when.
John?
Yeah, is it fair that we have a meeting between now and the middle of May to specifically get a sense of the committee's position regarding issues like administrative expense and other elements? You know, I'm hoping that, again, the way this is pursued is that at every variable, there's, you know, 3 options: the most aggressive, middle of the road, least aggressive. But you know, today's presentation, if anything, reinforces for me, I think there's $5 billion, if not more, dollars in administrative expenses that the task force left on the table. We're not doing our job if we don't insist on that more aggressive approach being included as an option in the model. Insisting that decision makers make a trade-off. If they're not going to take the aggressive approach, then they need to figure out a way to pay for that.
So to John's point, this was a question I had too as we were having the admin costs discussion. Is this something that Echo Northwest will help us with to perhaps revise the estimated cost savings, administrative cost savings? Is that part of your scope of work, or how do we get to that place where we're potentially suggesting an alternative to what we have in the task force report?
I think it's potentially part of our scope. I think we need, obviously, it's still conversation with the committee here to understand where the key interest points are. But that, I mean, yes, that is a piece that we can help out with.
I don't know, Andrew, if you were there for our discussion with Dawn. Were you listening?
Oh, yes. Yeah, most of it.
You know what all the topics are. Okay, good.
Yep.
Do you see this as realistic to have a committee discussion between this meeting and the regular May meeting as part of the, getting to the first deliverable, or would that be helpful, or what do you think?
I think it would be helpful.
Okay. All right. Good. Thank you. Richard?
Yeah, I think we need a few more passes and maybe some other experts, especially on the physician or ambulatory office side of admin expenses. It was interesting to listen to Dawn, but I don't really care about how much they spend on public health or how much they spend on building maintenance. What we really want to know from these people is what is the administrative billing expense, not general administrative expense about running a health system, but the administrative billing expense that we could potentially avoid if we went with universal health plan. And we need it tied down for hospitals, and we need it tied down for ambulatory offices in Oregon, or at least an estimate of that. So I still think we need some other experts to help out with that, whether they come from California or elsewhere in the US or internationally, I don't know. But I still think we got a long way to go to, as John said, of understanding the administrative expense and how much of that we don't have to pay for under a universal health plan. Thank you.
Thanks, Richard. Having been privy to that work, those attempts to bring in those experts from the staff, I know they worked really hard to try to put together a panel, and it just wasn't happening with people's availability. So if that's what this committee wants, I think we need help to make sure you identify and we invite, those experts to join us at this next meeting as soon as possible, because I know they tried really hard and it just wasn't working out.
Well, let's just do it one by one. If they can't make a panel, then let's take them when they can. But we got to get the knowledge.
Mm-hmm. Okay. And since we have all new staff now, I mean, I think we're going to have to. I don't know if you have all that information on who was being sought after, but we're gonna have to start again with a different date then, that means. So I'm gonna give it to Mimi first, because I have a feeling you have a response on this particular issue. No?
just a little bit on that. So there's an organization I've been working with through my master's program called Healthcare Financial Management Association, also known as HFMA, which has experts which are absolutely able to speak to some of those very direct cost questions. So I'm going to reach out to my contacts at that organization to potentially, so it may be something that we are able to provide. Yes, these are the numbers and we can do that. If not that, then sort of a speaker or someone else. So I can look into that contact. And then I was going to talk about other takeaways, but I will also work diligently on the potential for having an in-between committee meeting between these 2 days that we have scheduled.
Thanks, Mimi. And if we can get a date as soon as possible, I have a feeling if we schedule it during the usual week that we've been scheduling those supplementary meetings, I'm actually presenting at a conference that day. So I would need someone else to facilitate that committee meeting if it's the very first week of May. Mary Lou, did you have something? And then I think we need to probably wrap it up and go to public comment.
I was just trying to get to what the dates are and the fact that I knew that there had been an attempt to get a panel, but I don't know who they were. And so I'm kind of Johnny come lately and I don't want to cause any trouble here. So I'll follow up with Cheryl or Mimi and get some answers maybe.
And that's fine, Mary Lou. And if you have ideas, please send them our way.
I have one person that that is the management of a large group practice that I know personally, and might chat with him and see if he'd be willing to come and present or something. I mean, because I think that's part of it, is like having people be honest about what it's really costing them out in the field where they're doing the work. So anyway.
Absolutely. So before we kind of move on, are you all, we're not going to vote on this, but I want to make sure that we have consensus that you're open to scheduling another meeting in May, an extra supplementary meeting, because we have to have quorum even for the supplementary meeting. So at least 6 of us would have to say we're going to be there. Any concerns? Okay.
So you're saying not the 6th then that I had tentatively on my calendar?
It's an additional meeting.
Okay. All right.
It'd be in between this meeting today and the regular meeting in May, just to begin. I think well, in my opinion, we just need to go maybe 1 month at a time or a couple months at a time, decide whether we need supplementary meetings, but we'll see where we get by the end of May, and then we can maybe make a decision for the next 3 months or something like that. So, did anyone else have anything? I thought I saw a hand up, but maybe I missed it. Okay, any other reflections or topics that you believe we must include in our upcoming 2 meetings in May? Charlie?
I mean, I think I've already said this, but we need to talk about the topic that I guess, introduced last time, and that's the nature of the tax structure. So we have a lot of stuff to talk about with that. So. And
do you see that as being a discussion that we have with Echo Northwest, or should we be bringing in the Legislative Revenue Office or anyone like that? No? Mostly we need to have it amongst ourselves. I think Echo Northwest can probably help us there. I don't think we need the Legislative Revenue Office at this point, because it's not so much how much are we going to raise with each of these. It's like, what should the nature be? What should we do? What should we try to do?
Principles.
Just want to make sure
principles,
who we should invite. Okay. And John?
Yeah, just one important issue. At the task force, Optimus over and over expressed concerns that we weren't taking fraud and abuse seriously, and that it would cost hundreds of millions of dollars in administrative expense. I think we just heard this morning that a lot of fraud and abuse may be tied to the reimbursement strategy for providers, hospitals, etc. I'm sure we can't ever get to less than 1%. That was shocking. But you know, you sure would hope that we could get to a reimbursement system that folks would trust, would create trust, and not require enormous amounts of administrative costs for each side to be auditing, monitoring, checking constantly at great expense to the taxpayer. So at some point, that again is a potential significant issue.
Thanks, John. Mary Lou?
Quick question. In the administrative expense, are we supposed to be figuring in how much it will cost for people to become beneficiaries, as we was talking in Canada? So that piece of that.
Yes.
And I was also surprised that if they're folks that didn't have a home or had mental health crisis, or et cetera, went into one of their facilities, that they didn't just register them right there.
Me too. I was surprised by that.
We're doing that with Medicaid right now. I mean,
Exactly.
they're OHP eligible, the hospital gets them, you know, so anyway, it just was something that popped
You know, just I can't resist working. I worked for the Blues, you know, for 10 years. I never realized how complex and expensive the membership systems were and still are, I'm sure. Because in the case of Blue Cross, we had 2,000 different benefit plans and, you know, thousands of employers. And so people really underestimate how expensive the membership systems are. They kind of focus on claims. The big expense that could be saved is on membership systems.
Okay.
Okay, with that, I think we need to close it out. I would say, I mean, just my takeaways are that we need to focus on what's immediately in front of us at the moment and just get through May. I also will bring back our concerns on the timeline to the board. And we are having our big strategic planning meeting at the next board meeting. It's an extended meeting. And my goal is to get really specific on all of the deliverables of this committee and lay it out through September, perhaps beyond, sounds like, and just see, you know, what's doable and realistic, and then bring that back to you, you know, at the May meet. Well, it's probably this, well, let's see, I think the board meeting is after our regular May meeting, so it might be June-ish. But maybe we could even report back to you just by email or something, just so you have that information. And if you have suggestions, of course, you can reach out to me or to the staff in between, okay? So thank you. This has been a really great discussion, and we do have a lot of work ahead of us. No doubt about that. So with that, I'm going to open it up to the public comment section of our agenda. And we do have one person providing public comment today. That's Lou Sininger. So I'm going to call on you and invite you to talk to us.
Okay. Can you hear me now?
Yes, we can. Thank you.
Okay, I just want to thank you all for working so hard. I realize that you're behind the 8 ball, so to speak. Just remember, we're creating one plan that fits all, you know, and don't forget to take a look at, I know it's not your job, but to include visiting coding. As I understand it, family practices really don't need that many codes, that the codes have been invented by the insurance companies. And so now we have thousands and thousands of codes that are probably not necessary. Outside of that, I think I'm confused because if I was doing this by myself, I'd throw out a plan that this plan is going to cover this much. And then I'd figure out what the cost is, and then I'd figure it, and then I'd, you know, adapt to that, process it through. So I don't know how you're going to do this, But I think Charlie's on the right thing. Anyway, getting started, the nature of the tax structure, that'll get a good start. So thank you, folks. You're doing a great job. One plan fits all.
Thank you so much, Lou. Appreciate your words. So with that, we'll adjourn and you'll hear soon from staff, I believe, when that next supplementary meeting will be, and we'll have an agenda soon. Thank you all for your work. Really appreciate all of you. Bye-bye.
Thank you, Cheryl.